Good morning and welcome to a special edition live chat. I'm Rebecca Fuhr. Today we'll be talking to clinical services about the changes to our MAP program. Questions can be sent to our normal DOC_questions inbox. If you would, please put your questions to the normal DOC_questions inbox, but in the subject line, if you would, please put clinical in that subject line. And as always, if you miss any portion of today's chat, I'll always put the recording on the front page of DocNet under Executive Director Live Chat. Our panel today is the Director of Clinical Services, Lacey Monday, our Assistant Director, Lenny Woodson. I also have our Chief Medical Officer, Dr. Mall, and our MAP physician, Dr. Kruger. Thank you so much for joining me, everyone, and good morning.
Good morning. Thank you so much, Rebecca, and thank you everyone for taking the time to hop on and get some of the answers to your questions, hopefully that have been in your mind for the past however long it's been that we've been doing MAT. So we wanted to start this live chat with Dr. Kruger going into an educational session to explain how our MAT program works and some science behind it. And then we'll leap into any of the questions that were listed that we aren't answering during the educational piece and any questions that come in throughout the rest of the hour. Okay, Dr. Kruger, I'm going to pass it to you.
Sure. I just have a little blurb about some education pieces, but more than happy to answer any questions about the MAP program. I think, before I even got into addiction medicine or family medicine, it was really difficult for me to understand patients with opioid use disorder or any substance use disorder for that reason, because they seem to make decisions that would defy all logic or reason. We had patients who would leave against medical advice from the emergency department or the hospital, even if they were having a heart attack or if they had a severe bloodstream infection. It's just really difficult to understand, right? Why would you continue to use heroin or fentanyl if it had been such a problem? And even now, I see patients who regularly continue to use, even though family members no longer trust them, talk to them, allow them in the household, even though they've gone through a divorce, even though they've lost custody of their children, even though they've been incarcerated, and even though they've been incarcerated repeatedly. Why are they still using, right? Don't they care about other people? It just seems like there's no consequence that is truly bad enough, and it doesn't make any sense outside of this schema of use. But I think that's kind of the point. The compulsive and irrational behaviors that we see in these patients are not only diagnostic of an opioid use disorder, they're really a sign that something much deeper is going on. Using illicit opioids like heroin and fentanyl in high amounts and over a long period of time, it fundamentally changes the structure of the brain. Illicit opioids target the brain's main reward pathway so that people will continue to use no matter the consequence. I don't know about you, but I don't know of anyone who's used heroin for more than 20 years who's completely back to normal after a 7-day detox. The brain just doesn't work like that. Unfortunately, of all of the organs in the body, right, the brain is one of the slowest to recover and to heal. We use medication, and I mean medication, whether that's methadone, buprenorphine, and that would include suboxone, Subutex, Zubsolv, Sublocade, or naltrexone, which comes as a pill, or a Vivitrol injection. Really, we use medications to help neutralize some of these brain changes, and medications are an important piece of sobriety and recovery, just like behavioral health and healthy coping mechanisms and lifestyle habits. Another way that I think is a little bit easier to relate is we can think about medications for opioid use disorder and treatment of opioid use disorder as similar to the treatment of other health conditions that requires both medication and lifestyle changes. So for example, diabetes, high cholesterol, and high blood pressure being part of those.
So Dr. Kruger, could you explain a little bit, I'm not going to take much time on this, but could you explain a little bit, first of all, how the the brain develops those kinds of connections to start with in a healthy environment, in an environment where, okay, this is the action, here's the positive reinforcement. And then can you elaborate on what happens in that circumstance where there's a maladaptive reinforcement for a behavior? Specifically, I'm asking about the dopamine process.
Sure. I don't want to get too technical or like too over everyone's head, right? But when you use opioids, they act on an area of the brain that leads to a big dopamine response. And dopamine feels good. And it feels really good. There's a lot of things that we do in normal life that lead to a dopamine response. For example, sex can lead to a dopamine response, or like eating a really good meal like out at a restaurant leads to a dopamine response. That is part of normal physiologic processing. And when something feels good, we want to remember it, right? It's salient. And when it feels really good, you're like, you know what? I know what feels good. Opioids feel good because they lead to a really big dopamine response, right? Like we wouldn't be doing this if it didn't on some level feel good. And then what happens over time is your brain adjusts to having that level of dopamine, right? There's changes that happen in the brain with upregulation, downregulation of receptors in certain parts of the brain that have adapted because you just can't handle constant dopamine overload all of the time. And so your brain gets used to having that level, and that is the new normal. Eventually, what it means is when you don't have the substance, you start to feel bad. And that's why we see patients who are using heroin or fentanyl over a long period of time who develop withdrawal symptoms, right? And that would seem similar to the flu, feeling unwell, having body aches, being in pain, nausea, vomiting, diarrhea, lack of motivation, lack of appetite. All of these things are related to a new normal or a new brain baseline. Also, we see that other areas of the brain that are involved in decision-making and in memory, they also have kind of like an overload of stress hormones that, in addition to just not having the substance, part of the brain just feels really unwell, like this experience is so distressing that you also want to remember that, right? Like part of the brain is to remember good things, but also to remember bad things, just like, yikes, I don't want to do that again. So all of these things happen where it's not eventually not just about feeling good, but also about not feeling bad.
Mr. Woodson, do you have a response?
Yeah, so not necessarily a response, but I think this is a good segue. I wanted to sort of back up some to just really take a minute to thank some of the members of our clinical team who developed the new MAT training that just rolled out this past week. Wanted to give a special shout out to our nurse educator, Monica Reese, who was the person who really put the finishing touches on that, and that's her voice you hear in the video. Also, Dr. Kruger, our MAT physician, our MAT pharmacist, Dr. Olu Watamelon, sorry, Dr. O for the pronunciation, Dr. Mall, and others, and I'm sure I'm forgetting to mention. I don't know that everyone in the department is aware, but we're pretty fortunate to have an addiction-trained physician and a pharmacist who has work experience in an opioid treatment program. They're heading up our MAT program, and that's different than some other departments across the country. We do mention in the training video that the MAT program is, of course, required through legislation, through 2 separate bills to be specific. But beyond that, MAT is really the gold standard for the treatment of opioid use disorder. Pairing medication with behavioral health treatment for the best possible outcome. And over the course of the last several years, our department has consulted with other Department of Corrections across the country. We've partnered with multiple and consulted with multiple organizations really to implement an evidence-based MAP program. Really of note, we've partnered with the Pew Charitable Trust. You may have heard of that group. The Colorado State Opioid Treatment Authority, or SOTA, Ryan Mueller, and the Behavioral Health Authority, just to name a few groups that we've really partnered with. With that being said, though, we're continually striving to improve MAT and DOC. The clinical MAT team that's here today, along others in the clinical program, we've been working alongside wardens to revise our MAT policy. The program is going to continue to evolve and improve, and our transition from suboxone films to suboxone tablets, that's just a small piece of that evolution. One thing that I know we'll mention when we respond to the questions that we've received so far is that the tablets that we're transitioning to do absorb faster than the films, and crushing the tablets, that's expected to decrease misuse and diversion, and it's going to allow them to dissolve even faster. One other final point I wanted to make before we get into the next piece of this, and Dr. Kruger touched on this, but opioid addiction really hijacks the brain, by causing structural changes that can last for years. The medications that we're offering, that we're giving our inmate patients, that really gives them the ability to absorb the behavioral health treatment that they're receiving. So we really need both of those components for the best possible outcome. And MAT is preventing overdose deaths. And the fact of the matter is that dead people just don't recover. And MAT is giving them that opportunity to recover. So I'll turn it back over to you, Rebecca.
Thanks so much. Let's turn to some questions real quick. And I do want to remind everyone that is listening, if you do want to send in those questions, send them to the normal DOC_questions inbox. Just in the subject line, put clinical, so we don't get them confused with all the other live chat questions that normally come in. So this is a question. We are switching from the current melt in your mouth suboxone strips to tablets. I assume the tablets are cheaper because the inmates will just cheek these too. The only way I know to stop the passing of suboxone is the shot. This would be the safer option for the safety of all staff and offenders.
I can take this question.
Okay.
So I appreciate the question. I'm glad this was asked. As I'd mentioned before, yes, we are switching from suboxone films to the tablets. Again, the tablets will be crushed. We're expected that that's going to further decrease misuse and absorb faster than the films. The injectable form of medication, we have piloted what's known as injectable buprenorphine, or its brand name is Suboxone, Sublocade. That was piloted at Sterling Correctional Facility. We purchased that with grant funds. Right now, Sublocade runs around $1,800 a month per patient, compared to the $10 a month that we're paying for Suboxone tablets. So yes, the tablets are cheaper, but we think they're a more efficient use of funds.
Thank you. This writer says, when I worked for the Office of Behavioral Health, or OBH, when someone was getting Suboxone through one of our programs licensed by OBH, there was a therapy component. In addition to the medication, the patient was also required to participate in talk therapy. Is that something that is being provided within the DOC facilities?
Sure, I can take that as well.
Okay.
And I'll pass it over to you, Dr. Moll. I was just going to mention, we don't have Molly Carpenter, our substance use disorder treatment program administrator, on the call, but Molly and her team have developed a talk therapy or group therapy component that is the behavioral health side of MAT. In addition to that, a lot of the individuals who are enrolled in MAT or have an opioid use disorder are not just using opiates prior to coming into DOC. They're using other substances as well. So they're likely on the referral list for other treatment programs, substance use disorder treatment programs. So that may be therapeutic community, that may be outpatient treatment. If they choose or are not able to participate in behavioral health therapy while they're in DOC, they are referred to programming in the community. Many of our individuals participate in our InReach program, which is headed by our Chief of Community Behavioral Health, Jason Guidry. That's the program where we really work to pair them up with a community treatment provider, which often has MAT services. Pair them up with that provider before they release. So they participate in an intake appointment while they're still incarcerated, and then connect with that provider in the community. Dr. Mull?
You covered basically the entire process, but I think I would like to just reflect on what you said a moment ago. You're absolutely correct. It's a two-part process. Medication allows the calming, I would say, of the brain to an extent where the actual talk therapy begins to help. Without it, it's very difficult to get that accomplished. Our goals right now, and I think one of the things we didn't talk about is the overall goal is addressing everyone within the prison who has opioid use disorder. But right now, what we're trying to do is to get those areas that are the highest risk. As Mr. Woodson said, dead people can't recover. So we are trying to focus on those that are leaving our incarceration so that they have a chance when they get back out. The likelihood of overdose within the first 2 weeks after leaving prison for someone who has no medicine, nothing, no talk therapy, no medicine, nothing, is 129 times more likely to overdose and die. Well, that's staggering, absolutely staggering. So we can't ignore that particular statistic. We have to address that statistic, and that's what we're doing. We still value the talk therapy. We still try to get them hooked up outside with a provider that will provide the mental health aspect as well. But we have to stop it. The fastest and most effective way is giving them medication. So that would be the only piece that I would add to that.
Thank you, Dr. Mall. How long does it take for the crush tablet to dissolve under the tongue? That was the issue with the sublingual film at the Medline. It took so long to dissolve that they were diverting as soon as they left Medline.
Dr. If you want to take that, or you take it? I'll give it a go. So the film takes somewhere around between 10 and 15 minutes to completely go away. Now it adheres to the cheek within 90 to 120 seconds. That's 2 minutes. Now I want to say this again, that it adheres to the cheek and it becomes very difficult, if not impossible, to peel away in that time frame. I understand all of the shenanigans that are out there to happen. I get that. Peanut butter, Vaseline, pick a process, cellophane. I get that. But the point is that the film itself adheres, then it dissolves over the course of the next 15, 20 minutes. That's a reality. Now, having said that, the tablet is placed under the tongue. It's not floated. It's not powdered and put in some liquid. That's not how we do it. It's crushed into kind of a granular, almost gravel-like consistency, and then put underneath the tongue. In that environment, that dissolves within 2 to 3 minutes. 15 to 20 minutes, 2 to 3 minutes. Doesn't mean it's not. There was some other concern there, some other questions about, well, it's no longer any good after a minute or 2 minutes. That's not correct. It dissolves in that period of time under the tongue. Now, can they still divert? I suppose they could take a piece of that granular stuff out, but it also adheres to the tongue, under the tongue mucosa. So it overall is going to be far better with the diversion process against diversion than the films are presently.
Thank you. Does suboxone create a similar side effects as an opioid, such as constipation?
The answer is yes.
Sure, I can take it. I mean, all opioids cause a similar set of side effects, but to varying degrees, right? Opioids can cause dizziness, drowsiness, sedation, constipation. Even for patients who are on opioids as part of cancer treatment, right, or chronic pain conditions, they could experience those side effects too. So for anyone who's on an opioid, yes, I would recommend a bowel regimen or like treatment with a laxative, like Miralax. I think in general, buprenorphine is one of the safest opioids out there. For example, other opioids like heroin and fentanyl, they can cause respiratory depression and cause patients to stop breathing and die, right, an overdose. I have not seen someone who had a similar effect from suboxone. I just haven't seen it.
Thank you. And this writer writes, in the course of my work, I've noticed many more incident reports about drug use, and I'm informed that this increase involves suboxone. If true, why?
So I'm going to take the first volley on this. I think it's important to understand that suboxone is coming into the prison other than through our pharmacy. And I'm not slighting that in any way. That's a very serious problem. But one of the things that happened, oh golly, it must have been 18 months ago or so, Mr. Woodson, we had the same question asked, and our films were a particular color, the ones that we were actually prescribing. The films that were coming in that other folks were being found with were a different color. So yeah, you're absolutely correct. Suboxone is within the department. You're absolutely correct, but not all of it's from us. And that's, I think, an important piece to understand. So then comes the question, and there's Rebecca, how many questions do we have?
Many more coming in. So I'm not entirely sure. Yeah, many more coming in.
I'm glad to hear this, because there's a lot of conversation that is occurring in the periphery that I hear when I go to the facilities that I'm not hearing in this meeting. So I want to make sure that those things are aired. This is the place for that. But you're right. The actual question then is, how many people have OUD within the department? And Dr. Kruger, I think you have a great answer to that question.
I think at least last time I looked, we had about 15 to 16,000 inmates. I would say data from California, for example, suggests that about 30% of all state inmates have an opioid use disorder. We also know from, I went to the Maine Department of Corrections, and they're treating about 42% of their inmate population with suboxone for opioid use disorder. So I would say probably about 30, maybe 40% of inmates have an opioid use disorder. Right now, we're treating about a third of those. I would say we have about 1,000 people on treatment. I would say roughly about 750 to 800 who are on buprenorphine, a little over 100 who are on naltrexone, and then the remainder who are on treatment with methadone.
Thank you, Dr. Kruger. I'm not sure which one of you want to take this question, but what is the COPD process for those that continue to divert medication for misuse? Are we ever going to hold the offenders accountable and discontinue their access to suboxone?
I'd like to take that.
Sure.
I'd like to take that. So I'm diabetic. I use insulin right here, and I have to fill it every now and again. To be very specific, every 2 to 3 days. I really like that pumpkin Pepita loaf at Starbucks. I really try not to get it, but I really like it. It gives me a dopamine bump. Does that mean that Cigna is going to get word that I'm eating that Pepita loaf, and they're going to say, Dr. Mall, I'm sorry, you can't have any more insulin? It's the same concept. You're right. I get accountability is one of the things that is our mission statement. If you take a look at our mission statement from a couple of years ago, that was part of it. It literally said accountability. But we also have to have a certain understanding of the disease process or the condition process and realize, I like that Pepita loaf. Okay, fine. I won't have it this whole week. But I really like that Pepita loaf. So there's going to be this process where there's going to be slippage. I get that. And yes, we hold them accountable. Guess what? If they go do it 3 times, we withdraw and we reintroduce it, because that is the recurring relapsing condition of addiction.
Thank you, Dr.
So
Mall.
just to expand on that some, and Dr. Mall is absolutely right. You know, this is a medical condition that we're working to treat. Addiction is a challenge, to say the least. Accountability is definitely a part of the MAP program. In the training video, we have a portion in there. I think we titled it custody or security considerations. This should be an observed process. We should have staff watching to make sure that these are being administered and that patients are not attempting to divert. As Dr. Mall mentioned, we have sort of a 3-strike policy where we can take somebody off of the medication and give them an opportunity later on in the future to come back if they choose to receive the treatment again. So accountability is definitely a part of the process.
Thank you, Mr. Whitson. Let's see. Next question. I wish we would have more behavioral health therapists. I absolutely believe this is a huge part of this process. Do you think we will be getting more behavioral health specialists? I'll ask Director Monday.
So we're actively recruiting behavioral health therapists. And as everyone knows, we have a big discrepancy in vacancies and individuals that are actually in those positions. Something else that I think we don't talk about enough is when this program was mandated, we did not get positions funded to provide the service. So that has added some complications in implementation. That is something that we are moving forward with requesting in the future to support this program in totality. But hopefully in the next year, the next fiscal year, we will be able to hire more DOC therapists that will support this program.
Thank you. When an offender changes facilities, will his prescription have to go with them, or all facilities going to have suboxone? Who wants to take that one?
Could you repeat the question? I don't quite understand it.
Sure. When an offender changes facilities, will his prescription have to go with him, or are all facilities going to have suboxone?
Yes, yes, and yes. Everyone. Okay, so let's step back about the 15,000-foot level and look at it. We have 17,000. We have 30% that comes somewhere between 3,500 or so that probably have OUD. Some of those may be diagnosed. Some of those may not be diagnosed yet. We have 5 people presently working towards MAT, on MAT. If you take a look, you do the numbers. I mean, we're looking at 3,500 people. That's not going to work out in a timely fashion. Our goal is to meet the need of every person within the department who has OUD. It's kind of related to that previous question before. Suboxone is still coming in. People are still using it. We're going to try to replace that with the stuff that we're actually prescribing. Oh, and by the way, we're going to include the fact that with the mental health component. So if we have that number of people and we have to meet that need, there's no way that those 5 are going to be able to do that moving forward. So in answer to your question, yes, the prescription will go with them. Yes, there's going to be Suboxone at every facility. Yes, there's going to be an expectation of each provider to be a part of that program. Once upon a time, remember back, we had a situation where I requested everyone get their X waiver, and everybody did. Thank you. Guess what? Now you don't have to have one. It's a situation where this is recognized as such an important issue that SAMHSA has removed that requirement. We still have to work collaboratively. We still have to help each other understand what we're doing, but every provider will be a part of this program over the course of time.
Mr. Whitson?
So I think Dr. Mall was given a 15,000 foot view. To bring it down to ground level right now, we don't currently have the infrastructure to support offering MAT at every single facility across the state. That is a longer term goal. As county jails induce more people or bring more people into the department that are already on MAT, MAT is going to continue to grow outside of us inducing individuals on MAT. So we know that that number is going to grow. We know that we are not treating the 3,000 or so individuals that likely have an opioid use disorder. So we're going to have to get to that point eventually where every facility has the ability to offer MAT. We're not there yet. Working through with infrastructure money that we received from the legislature to make changes to some of our clinics across the state. That process is ongoing right now. We have construction, I believe, at Sterling, Territorial, Fremont, other facilities to support that growing need. So we will get there, but we're not there yet. Also, I wanted to make the point too that we'd like to, in the future, have stock suboxone in our facilities. That will really help our pharmacy. That's another concern that we have, is that as we grow, that we're not outgrowing the capacity of our pharmacy as well.
Thank you. This question says, suboxone sublingual tablets must be administered whole. Do not cut, chew, or swallow. So why would we crush if it is not supposed to be? Dr. Kruger, this might be a question for you. Or maybe Dr. Mall.
Yeah, sure. So this is taken from the package insert, and these are instructions for how to administer Suboxone tablets. I have a feeling that this was written on the package insert so that people don't take, like out in the community, not in prison, people out in the community don't break their tablets and misuse them, right? Inject them, melt them, etc. It is common practice in addiction, even with the Suboxone film, to instruct patients as a medical provider to cut the film to get an appropriate dose or to split film. So even though this is kind of on a package insert, this is already something that is done in clinical practice. Beyond that, before we made the decision to move to crushed Suboxone tablets, I actually called every single jail in Colorado. I also spoke to other state prisons, so for example, in Washington, where they are already using crushed tablets. The issue with using a whole tablet in the facility is just like the film, right? You could take a film, put it on the back of your ID card, never put it into your mouth. Tablet, you could just take it and put it directly into your pocket, right? So the idea is that crushing the tablet will lead to less misuse. And that is why some of the other facilities are already doing this. This has already been proven as a kind of a proof of concept because it's functional at multiple other facilities. I think in a correctional healthcare system, personally, this is the way to go to prevent misuse of the medication. And then, sorry, just one other piece. There's no, at least in talking to these other jails and prisons, and then also thinking mechanistically about how the medication works, there's no reason that I think that crushing the film will lead to decreased medication effectiveness. So I think this is still an appropriate standard of care.
Thank you, Dr. Kruger. This question says, smoking, what high do people experience? How much is needed for that high? How long does the high last? How many smokes can someone get from one strip? Who wants to take that one?
I'll start. So I think we can think about things as relative, right? If you're taking, let's say you're taking oxycodone or OxyContin for cancer or for chronic pain out in the community, right? You actually don't experience any euphoria because you're getting the same dose day after day after day after day. So if patients are on Suboxone and taking their dose every single day and taking their full dose, they don't experience any euphoria. That's the point. It keeps them controlled. It neutralizes some of these changes without out some of the other factors that, or I guess maybe some of the other side effects that opioids can cause that will lead to problems, right? We don't define an opioid use disorder based on how much someone's using. We define it based on how much it's messing up their life, right? If you're out getting intoxicated, falling asleep, nodding off in the corner, then you can't participate in meaningful, healthy relationships. You can't go to work, right? Because you're pretty much using on the job. I can't tell you how many people I've talked to that are using even while they're like operating heavy machinery, while they're in construction. It's insane to me. But the goal of suboxone would be to neutralize some of those changes. You don't have any euphoria. You don't have any impairment in your life. You're just kind of at baseline. That being said, suboxone is an opioid, right? So it does have some opioid properties. If you were down at 0 and you had never used an opioid in your life, it is possible that you might experience some euphoria from suboxone if you did not have an opioid use disorder and you were not using opioids regularly. I think that euphoria from suboxone would be relatively mild compared to any other opioid that's out there. Do I know, exactly what level of euphoria or intoxication people experience from illicit suboxone? No, I'm not an expert in that. Also, I think it's hard because patients are using multiple different substances at the same time, right? Like a lot of patients will use IV methamphetamine and will combine suboxone with that in order to combat some of the agitation associated with meth intoxication, right? So like how can you tease out what's suboxone versus what is other substances? Also, another interesting thing is when we did go to Maine and they are treating all of their patients with an opioid use disorder with suboxone, what they found is that some patients still continued to inject, and even though they weren't injecting anything, they were doing safety. And they, like, despite treatment, there were still some injection behaviors that happened, right? So like even if we were to treat people fully, would I say that suboxone is as effective injected versus under the tongue? No, right? Just mechanistically, no. But I guess what I'm trying to say is even if we treat people completely, we will still see some adherent use behaviors, right? Injection of saline, we still see other substances. Anyways, sorry, long tangent.
Thank you, Dr. Kruger. This is a comment on actually some questions on the educational video. Here are some concerns that this person had on diversion. We must have more strict guidelines for offenders that divert this drug. If offenders are taking this drug as prescribed, it would not be a safety concern. The issue with diversion is that they are not taking this as prescribed. Our intel is stating that they are putting it in their eyes or melting it in and injecting it. This poses an increased safety concern for our offenders. We wouldn't give them other prescription medications if they continued to misuse it. Dr. Mall.
I'll start first volley on that. For starters, one of the things that I think is really important to understand about suboxone in general, or buprenorphine in general, let's separate the components. I think that's an important piece as well. Suboxone, whether it comes in a tablet form or a film form, contains two medications, naloxone as well as buprenorphine. Buprenorphine is an agonist-antagonist, meaning that it binds with a receptor, but it only binds with half the receptor. Let me put it that way. Now, there's some details in chemistry that we don't necessarily need to get to, but the intention is that it's a partial agonist. That means it's going to bind halfway there. That's why there was a question earlier about the bump and the rush and the dopamine release, etc. It isn't the same as, say, heroin, and it lasts longer and secures. We'll look at, given we're talking about security, it secures that opioid receptor half on, half off, and that's where its benefit comes from. So let's put that aside. Let's talk about the naloxone piece. There was a comment made about putting it, melting it and putting it into their bloodstream, or dissolving it and putting it in their bloodstream. That's what the naloxone is for. It counteracts. It's formulated for this very purpose, to keep that method of diversion from giving a rush, because there's the partial agonist buprenorphine, but there's the complete antagonist of naloxone. So when it gets injected, it doesn't have that bump. Okay, it doesn't have that positive reinforcement. So that's an important piece to remember. The other thing about putting it into a mucous membrane in the eye is very similar to putting it in a mucous membrane in the mouth. Both of those areas bypass what's called first pass metabolism. It's another chemistry thing we don't have to worry about right now, but it bypasses. So it would be as effective putting it in the mouth. Melting it and putting it in the eye really doesn't do much at all as far as any different type of presentation or administration.
But we have offenders that are taking this medication that have never had a drug program before, but now they're on the MAP program. How do you respond to that?
Rebecca,
Sure.
I want to go back, sorry, just 1 second, to the question about diversion. And I
Yeah.
do want to note that clinical and prison ops, we're working together. We've created a working group to look at our operations and how we are administering MAP medication. So I'm hopeful that we can get all our brains together and come up with some solutions to all the concerns that are brought to our attention around diversion.
Thank you.
And I also just wanted to say, as a medical provider, I think there's times where patients don't necessarily adhere to treatment recommendations, right? So you, for example, could think about someone with diabetes who doesn't really want to make a lot of changes to their diet, right? I personally don't want to stop eating ice cream or stop eating sweets. Like, that's the best part of my day, right? But am I going to stop treating them with insulin? No. Like, am I going to take away their metformin? Also, no. I think when we did this Sublocade pilot at Sterling, what we noticed is that when people were taken off of medications, like when we took them off of Sublocade or suboxone, we actually saw a rise in the use of illicit fentanyl. So just kind of keeping in mind, right, like the nature of an opioid use disorder is that you'll use compulsively kind of no matter what, right? And so taking away a treatment option really isn't helping this patient population. Like, above all else, I feel like we need to keep people safe, and that means from dying from an opioid overdose, and that also means certain types of medical consequences as related to use, like HIV or hepatitis C or severe bloodstream, like heart valve, bone infections that are a result of use. So I think it's a delicate balance. Like, obviously, I would like to keep the facility safe. I also want to keep patients safe and healthy, and we're kind of working to find that middle ground.
Dr. Kruger, what are the odds that a person comes off MAP eventually, or can they? Do they just stay on it forever?
Sure. I will say, when I first went into addiction, my dad asked me this like all the time, like when is enough, right? Yeah. And I mean, now he shows me like Washington Post articles and stuff like that, like, oh, this person died in Virginia from a fentanyl overdose. Super into it now. But my answer that I always tell him is, we don't know, right? Do I see someone who's been using IV heroin that's 80 years old? No, right? That is unfortunately the nature of opioid use disorder. You just don't live long enough. The risk of relapsing to illicit opioids like heroin or fentanyl is about 60 to 70% in the first month with no treatment, right? I would say out in the community, if someone wanted to come off of treatment, of course I would support that. Usually I wouldn't even I would never bring up the conversation. But if they didn't want to be on treatment, I would usually say about at least 2 years of time out in the community, not here, right? But out in the community, of sober time on treatment. And the people who are ready to come off treatment, like I had a patient who had been on suboxone for 5 years, who was working as a counselor in a drug treatment program, who was engaged, living with his fiance in an apartment, right? And he was like, please do not take me off treatment, right? Because he knows what the alternative is like and how difficult it was for him before. And he's like, I have a good thing going. I'm stable. Why would I don't want to rock the boat, right? That might be someone that might do okay coming off of buprenorphine or coming off of methadone, maybe transitioning to a different treatment. But I think, you know, in a perfect world, we wouldn't need any medications, right? We wouldn't need any medications for diabetes or hypertension or whatever, but this isn't a perfect world. And these aren't like perfect ideal patients. If a medication helps keep you safe and healthy, why stop it?
How soon do you think DOC will know what to expect for the MAP program as far as success? Does that mean 2 years? Does it mean 10 years? How do we know when MAT is successful or when it's not successful?
I would counter,
I can start this.
what is success?
Mr. Wilson, do you want to answer?
Sure. I think I was going to say a lot of what maybe Dr. Kruger was going to say. I think we would want to first define what we mean by success. There are a lot of measures that we're looking at. To back up some, shout out to Ed Cayley and his team for creating tableaus for the clinical MAP team. We're pulling a lot of data that we're tracking to measure success. So some of the things that we're looking at, overdoses, we're looking at time in treatment, so treatment engagement, and then we're looking at, as people transition out into the community, are they remaining engaged in treatment, both behavioral health treatment as well as the medical side of treatment. We've also partnered with CDPHE to receive some community data, also looking at fatal opioid overdoses. So all of that information, in my eyes, is how we define, is the program being successful? Are we seeing a reduction in overdoses? Are we seeing ongoing treatment engagement? Are we seeing people remaining engaged in the program? To me, that is what success looks like.
This person says, I don't have a question. I just wanted to say I took the training that is available through SOC Learns, and it covers most of all these questions that are being asked. The training was very informative, so thank you very much. So shout out to all the people that you mentioned and others who had a hand in that training. So thank you very much. This person writes in, so thank you. The black market rate for Suboxone is going $80 to $100 a day. This has been creating issues with other offenders who are not prescribed Suboxone. Is there a way to create an entire facility into Suboxone facility to eliminate the burden on families? I don't know who wants to take that question.
I'll start with that. I think we're all kind of thinking about what that would look like having a Suboxone facility. First off, I'll say that, we've already talked about the population that we believe has an opioid use disorder. That would more than fill one facility, unless we're going to try to fill a Sterling. Even that, I don't think would hold the number of people that have an opioid use disorder. Of course, there are a lot of problems with trying to isolate everyone with an opioid use disorder, everyone who's on MAP treatment in one facility. We get into a lot of different custody issues. Director Monday did mention that we are working in a working group with prison ops to look at some of these different ideas. So I don't know if that's something that we would discuss as isolating people on MAP treatment in one facility, but we are looking at how do we really tighten up security and make sure that we're limiting diversion in the best way possible.
Let's see. There have been some questions and rumors going around related to Suboxone and using narcotics to treat acute pain after surgery. Is it appropriate for patients to continue to Suboxone while taking treatment for pain management? Should Suboxone be tapered and once their acute pain is over, or restart their suboxone. Dr. Mall, do you want to take that one?
Okay, you can take it, Dr. Mall.
Oh, sorry about that. Either way.
I would say it's important to continue suboxone even if there's a need for, like, even in the event of an injury or an acute procedure, right? If we can think about suboxone just keeping someone at baseline, if we take away the suboxone, now we have to treat withdrawal plus acute pain. Where if we just keep the suboxone the same, all we do is treat acute pain. I think in the past, there was some idea that, you know, this patient population is really difficult to treat pain in general. And because suboxone, you know, binds so tightly to the pain receptors in the brain, sometimes other opioids don't work as well, right? It has kind of like a blocking effect. But the idea is that if you don't want to be dealing with this deficit, so you keep the suboxone on and then just add maybe higher doses of opioids on top to help control pain. It is important to control pain in this population. We do know that untreated acute pain actually is a risk factor for relapse for opioids. And that acute pain can become chronic pain that leads to development of an opioid use disorder. So just like everybody, even patients with an opioid use disorder, deserve appropriate pain management.
Thank you so much. We have come to almost the top of the hour here, certainly the end of our questions. So I'll give Director Monday the final thoughts. Director Monday?
Thank you so much, Rebecca, and thank everyone for coming to this live chat. I think it's very important that we take dedicated time. I know every week we get questions about Matt, and hopefully we're able to answer a lot of those questions today. As mentioned, the training video is very informative. It has a lot of the answers to questions that we receive continuously, so make sure that you watch the training. I know that there's also a lot of conversation around that this is statutorily required. I want to emphasize that yes, it is, but that's also the right thing to do. So I want to give the rest of the panel an opportunity to have any closing thoughts as well, but I just want to say thank you to everyone that was here to answer the questions. Dr. Kruger, I really appreciate you, and Dr. Mall, and of course, Lenny, I don't know what I would do without you helping out. So anyone else that would like to have a final thought?
I do want to say just real quick that all questions are welcome. All concerns are welcome. Before I sat in this chair, my perspective was completely different. So all of these things are welcome. I am more than happy to be partner with you to work your way through this concern. Golly, I was one of those people back in the 90s. This was a moral impediment. I was there. So let's talk together. Let's work our way through this process with this, and with the scientific discoveries that we have made within the brain. It's irrefutable that we're dealing with a brain condition.
I would just like to close with a reminder that, you know, I know there has been some pushback about implementation of MAT in the department. And we've already talked about, you know, it's absolutely a requirement. And beyond that, it is, you know, the best course of treatment that we have available. That may change in the future. There may be a new developing treatment that's better than what we have now, but this is what we have right now. And it is the best option, and it is saving lives. And I'd like to sort of reframe some of the concern in that medication-assisted treatment is not the issue. The opioid crisis is really the issue, and that's what we're trying to combat. And MAT is the treatment for that. So, like Dr. Mall, I'm happy to take any questions and answer them as they come through. So I appreciate the collaboration that we have with all the other departments across DOC in implementing MAT.
Thank you.
Okay, that's it. Thanks, Rebecca, and thanks, everyone.
Thank you. Have a great day, everyone.